All right, welcome everyone to GAIA's World AIDS Day webinar. My name is Beth, Geoffroy, and I'm the Director of Programs and Strategic Partnerships at GAIA Global Health. I'm happy to be with you today, marking this 35th World AIDS Day. The objective today is to provide an update on the state of the epidemic, both globally and in the small country where GAIA works, Malawi. I'm joined today by an exciting panel of experts in the HIV/AIDS world. One is still trying to connect from Malawi, so hopefully we'll have James Selemani on with us at the end. But first, Dr. Michael Gottlieb, longtime friend of GAIA and a former trustee, as well as a renowned HIV physician, immunologist, and activist. Welcome, Michael.
Thank you.
Thanks, Michael. Also, we have Dr. Jamie Houston, medical officer at PEPFAR, with extensive experience in Africa and Malawi specifically. Welcome, Jamie. And then James, who should be joining us, is a clinical officer and team leader for GAIA Mobile Health Clinics in Mangochi, Malawi. Welcome to James. If you all think of any questions as we go, please type them in the Q&A box. You'll see a button at the bottom of your screen. And we'll save some time at the end for the panel to respond to those questions. So with that, let's get started. My role today will be as a facilitator, but I wanted to first frame the discussion with a quick summary of the state of the epidemic globally. As many of you know, the past decade has been one of nearly unthinkable progress, especially in sub-Saharan Africa, and has prompted UNAIDS to establish the audacious goal of ending the epidemic by 2030. Let's take a quick look at a few charts from UNAIDS that show us how we're progressing towards that goal. This first one on the screen is AIDS deaths. The trend line here was growing steadily throughout the 80s and 90s before peaking at around 2 million deaths annually in the early 2000s. The progress since then has been remarkable, though. There are still more than 650,000 AIDS deaths annually. Also notable is the trend line is flattening in recent years, putting us off trajectory required to reach the target level of AIDS deaths set for 2025 by UNAIDS as a critical milestone to end the epidemic by 2030. COVID no doubt jeopardized progress across the globe, so it's important now more than ever that we continue to press forward. The next chart I want to show you is new HIV infections. So here, the trend line peaked earlier in the mid-1990s when 3 million new infections were occurring annually. Today, the numbers are below half of that level, but again, we're currently off target required to meet the UN goals for 2025 and 0 new infections by 2030. But now let's talk about sub-Saharan Africa. It's truly a success story. Since 2015, the steady reduction in new infections globally has been driven almost exclusively by success in sub-Saharan Africa. As you can see in each of these 8 small charts, most regions in the world have seen little to no improvement over the last few years, and in some, those downward trends that you see were reversed during the COVID pandemic, while at the same time, sub-Saharan Africa has improved markedly, especially Eastern and Southern Africa. Given that this region, which includes Malawi, is the epicenter of the epidemic, you can see that by the scale on the y-axis, noting the numbers. So the progress in sub-Saharan Africa is remarkable. I want to show you one more chart to illustrate this a bit more clearly. The red line here is the trend in new infections in sub-Saharan Africa, compared with the gray line, which is the trend globally outside of sub-Saharan Africa, showing essentially no change. Given that progress, the latest UNAIDS World AIDS Day report, which came out this week, it highlights inequities in the AIDS response between groups, particularly men and women, inequalities faced by key populations, and unfortunate inequalities between health outcomes for children and adults. Those gaps can be closed, though, with concerted efforts, including ensuring breastfeeding women and their children are supported to confirm their HIV status, to promote decriminalization, destigmatization, and inclusion of key populations, and intensifying investment to prevent new infections among the population most at risk, adolescent girls and young women. I'd love to get into all of this and more with our guests today. So with that bit of context, let's turn to our panel. First, Dr. Michael Gottlieb. Michael's widely recognized as the person who first drew the world's attention to the emerging health crisis that he witnessed at the UCLA Medical Center. Since alerting the CDC to that crisis in 1981, Michael spent the past 4 decades treating, caring for, and advocating on behalf of the victims, the virus's victims. Michael, help me do a little more context setting. You've seen both clinical and policy changes. How different is your work today compared with your work back in the 80s and 90s?
Well, thanks, Beth. Well, there's a huge difference between the early days and now. The changes since the first years of AIDS are kind of like night and day. There's been amazing progress, like unthinkable progress, as you described it, on so many fronts. One of them is testing and awareness of a person's HIV status. I think here, education's made a difference. HIV tests here in Los Angeles are so readily available, and they're encouraged in many settings, and they're accepted by the public, and there's less stigma attached to testing so that people can know their status and get treated right away. And I know testing, particularly of men in Malawi, was an early emphasis of GAIA's programs, and I'm sure continues to be. And then there's treatment. With regard to treatment in the 80s, there were no treatments at all. The prognosis was grim, to say the least, and people who tested positive or had clinically diagnosed AIDS were often advised to get their affairs in order. But today, a 25-year-old diagnosed with HIV who can access treatment and can take it, continue to take it, is projected to have a virtually normal lifespan. And that's incredible. And in the clinic today, we routinely utilize what's called a test and treat strategy, where the person can start medication as soon as they test positive, sometimes even the same day. They're even handed a sample packet to start taking medication. And treatment these days is usually 1 tablet a day, compared to the 90s when patients took up to 16 pills a day to control their HIV and to get their viral load to where we call it undetectable. And today, for patients who can't take medication or have difficulty taking meds, we have injectable antivirals where a person can get an injection every 2 months to control their HIV. The other thing that's developed here in the US, at least at this point, is that treatment is also the major form of prevention. You can hold on just a second. Just organize this. So treatment is also prevention. In other words, if a patient's level of virus in the blood is very low, what we refer to as undetectable, they don't transmit HIV to others through sexual activity. And we call this U equals U. It's the concept. The first U stands for undetectable, and the second U stands for untransmissible. So continuing to get state-of-the-art treatment in developing countries remains a very powerful tool because treatment also represents prevention. And Beth, in the last minute that I have, I want to mention PrEP, which stands for pre-exposure prophylaxis, where someone who does not have HIV but is at risk can be protected against acquiring HIV infection with an antiviral pill once a day or with an injection every 2 months. So these new long-acting antivirals could have an important role in both treatment and prevention in countries like Malawi and throughout the developing world, if they can be made affordable. And so with that, I'll stop.
Yeah, thank you so much, Michael. And you answered my follow-up question. So I think I'll move straight to Dr. Jamie Houston. Jamie works at PEPFAR in the Office of the Global AIDS Coordinator in Washington, D.C. He's worked at PEPFAR for the last 10 plus years in various roles at CDC and State Department, including a leadership role on the groundbreaking scale-up of Option B+ in Malawi. Option B+ was a plan that dramatically increased the number of HIV-positive pregnant women and their children enrolled in lifelong treatment. Thank you so much for joining us, Jamie. I provided a quick summary of the progress towards an AIDS-free world globally, but I'd love if you could share the relative progress Sub-Saharan Africa has achieved. Can you drill down a bit deeper and summarize the progress in Malawi specifically, starting with the explanation of the UNAIDS 95-95-95 goals?
Thanks, Beth, and thanks all for including me in this great event. I just have about 3 slides. So this first slide is really just highlighting what I'm presenting today is actually work that colleagues of mine from the Centers for Disease Control presented at an International AIDS Conference last summer. It represents work that occurred, or there are two surveys, basically, one that was conducted back in 2015, and then one that was conducted just last year during COVID. And so highlight both the remarkable progress that Malawi has made toward ending the HIV epidemic, as well as the need for continued partnership to achieve this 2030 goal of ending the AIDS epidemic. And so next slide. On this slide, I'm going to explain, on this slide, I'm going to explain just the what the 95-95-95 goals are. And just to orient you to the slide, right? So the blue bar in the graph on the right shows the results from the first survey, and the green bar shows the results from the most recent survey. The dotted line shows you those benchmarks, right? Those 95-95-95 goals. And each of them, right? First one is awareness of HIV status. So the number of, the percent of people that are living with HIV who know that they're HIV positive. The second bar there, called ART, is focusing on the number of people who know their status are then already on ART or are on antiretroviral treatment. And then the third one is of those people on treatment, how many of those are virally suppressed? And so connecting with what Michael was saying earlier, the goal is to get everyone virally suppressed, because it's not only just good for the patient, but it also prevents onward transmission. And so what you can see here is two things. One, we are already at the 95-95-95 goals nationally in Malawi for the second and third 95. And then third, there's still some gaps remaining. There's both remarkable progress on the first 95, but still some gaps to getting to the 95%. Next slide. So drilling down further into that first 95. So again, this is the knowledge of status. So what again that is saying the percent of people living with HIV in Malawi who know that they're HIV positive. You can see two things. One, on the left is a first map of Malawi that's showing you HIV prevalence in the country. And so this isn't new information. This is information that just for orientation for folks that are not as familiar, but that the prevalence of HIV is higher in the south of the country and lower in the north. On the second map, you can see overlaid in the same kind of at the province level, the awareness of HIV status. And so you can see that the percent of people living with HIV is also highest in the South. So similar in the places where the burden is the highest. And I think most remarkably, actually, and all the way to the right in those bar charts, you're again seeing the prevalence of HIV in the blue in the first survey and the one in the second survey in green. And in particular, I just want to flag or highlight that in the Southeast, so in the areas where GAIA works, as well as where the burden is highest, you see this decrease in HIV prevalence, which is quite remarkable over a 5-year period. And this is not because people living with HIV, there are less people living with HIV, it is because the number of people in Malawi is growing quite dramatically. The age of people in Malawi is quite young. And in the last 10 years, so in 2012, the number of people living in HIV was just, the number of people living in Malawi was just 15 million. Now the estimate's to be over 20 million. So there's quite a large youth bulge. So people under the age of 15. So while it is really impressive that we're reaching this coverage, we're also still having this challenge of, even though the prevalence is going down, the number of people who are in need is actually staying stable over time. And frankly, it's just really critical time period to make sure that we protect that new generation that's aging into this 15 to 64 age group. Next slide. And this last slide just kind of points us to some of the gaps remaining around, like, and where focus can go forward on, like, trying to reach that first 95. So just highlight again that it's really impressive, these improvements in both men and adolescents. So on the left, you can see there have been big improvements in 15 to 24-year-old and 35 to 49-year-old men, so adolescent men and working age population men, as well as for women across the board. Or the other ways you could look at this is that, looking forward, like, where are we not at 90% even? So we're at less than 90% awareness for men under the age of 34. So either for 15 to 24-year-olds or for 35 to 34-year-olds, and for women aged 15 to 24. So it's the adolescents and again the under 35-year-old men where the gap still remains.
Thank you so much, Jamie. Those results are really encouraging, and they do align with the progress GAIA sees in the areas where we work in the southeastern part of the country. You've noted that significant challenges remain in certain subpopulations, and you noted young men and women 35, or men up to 35 and women 35 and under. Is that right? Can you talk a little bit more about the challenges we're seeing in those specific subpopulations and maybe what we could do to address those challenges? Are they in testing, treatment, and adherence, or just in some of those 95s?
Thanks, Beth. I think that's the right question. You can see both the remarkable progress and still some of the gaps in the areas. And so in particular, it is really around awareness of HIV. So those that are aware of their HIV status are getting on treatment and are being virally suppressed, especially in Malawi and in the areas where GAIA works. But we still need to focus on identifying or having scaling up active case finding. So index testing specifically for these populations, or targeted community testing for men and young people. Further scaling innovative solutions like self-testing, which is or sexual network strategies, and then in particular, what's been scaling peer-led community-based services to reach and support adolescents and young people, youth and young people-friendly services.
Great, thank you so much. So it seems like we're still having trouble getting James on the phone. So I'll just give you an introduction to him and what he was going to talk about, and I'll try to take some of those points from the Malawi specific context in the areas where GAIA works. And then we should get into some questions from the audience. I've already seen some from Dr. Ellen Schell and from Marty, so thank you for those questions. And we received some in advance that we'll go over too. But James Selemani, he's a clinical officer and a team leader for our GAIA mobile clinics. Every day of every week, he leads a team that loads up medication and test kits for a multitude of illnesses and drives off into remote rural areas to provide clinical care for as many as 200 patients per day. James was one of our first hires for the mobile health clinic program, and as such, he's provided over 400,000 clinic visits in his role in the past 15 years, including providing HIV testing and counseling for many thousands of rural Malawians. When we started this work, when James was first hired, we saw incredibly high HIV testing rates. We were testing, or as many as 23% of the people we were testing positive. Today, those rates have gone down to about 2%, slightly higher for men. Men typically access care less often, general health care less often, and so they come to the clinics less frequently. As such, we usually find them positive with HIV later in their infection, and they tend to be more likely to be tested positive when they get tested. There were also issues of stigma, discrimination, lack of understanding of correct and comprehensive information around HIV, and those conditions have really changed. If James does join, what he was going to say is the different interventions that GAIA has implemented to bring down stigma, to bring down the rates of the positive rates. He was also going to talk about the targeted interventions that GAIA implements to target those key populations Jamie mentioned and that I mentioned earlier, referenced in this week's UNAIDS World AIDS Day report. Those inequalities between men and women, key populations, and children and adults. GAIA is really trying to address each one of those inequalities. For adolescent girls and young women, we have a program across 2 districts that targets adolescent girls and young women, those that are at extreme high risk, maybe living with a parent that has HIV, and we support them. We support the whole person. We keep them in school. We ensure that they're tested if they need to be tested, that they have support systems to help them stay negative if they're negative, or stay on treatment and achieve viral suppression if they're positive. We also target key populations and men through our mobile health clinics program. We try to reach out to sex workers who roughly 50% of sex workers in Malawi are living with HIV. We reach men. We make testing easy and convenient for them. Actually, it looks like James has just joined, so I want to let him say hi. Maybe Chloe, you can switch over to him. And hi, James. Thank you so much for joining today. James, just want to see if you can hear me. If you can come off mute, if you can hear me.
No.
we can hear you. You've got a little bit of an echo.
Okay, so now it seems I'll connect soon.
All right, well, we'll let James get connected. Maybe we can go to some audience questions in the meantime, and then James can talk more about GAIA specific efforts to reach these different populations in Malawi. We had some that came in advance, so I'll start with one for Jamie. Maybe, Jamie, you can tell us a little bit why Malawi, you think, and what your research has shown, is why Malawi is doing so well compared with even North African countries or other areas across the globe. Why is Malawi doing so well in the fight against AIDS?
Well, I mean, this is taking us a little bit back a couple of years, but 10 years ago, Malawi was the first country in the world to really introduce Test and Start. This is well before we did this in the United States. And frankly, it was done by the Ministry of Health with support from Global Fund and PEPFAR. But it was considered quite, not aggressive, but it was very ambitious. I'll just say that. Like there was thought to be very, we didn't have the randomized clinical trials that showed that it worked at that time, but they felt it was ethically necessary. And to be honest, the ministry wanted to go further than the donors were willing to support. They wanted to do it for all people, but the money wasn't there and the evidence wasn't there. And so they started with pregnant and breastfeeding women, and they monitored it really well. And frankly, it was the data from the Ministry of Health in Malawi that then changed the WHO guidelines that then led to Test and Start being adopted. I mean, there were many other things to it, but I do think that that core principle of the ministry and the people on the ground driving this and making practical decisions to reach the people that they're trying to reach, or to make sure there's good services, as well as kind of using data to write that. That's really what has been true since the beginning of the program in Malawi, well before, you know, I don't know, I ever worked with it, but I think that's really the driving force.
Thanks, Jamie. I do think the Malawi government really does strive for the gold standard. You mentioned they adopted the strategy even before the US. So I think that's a real testament to their commitment to ending the epidemic. James, can you hear me?
Yes, I'm now connected.
Wonderful. Okay, I can hear you. So
After struggles, yeah.
No worries. We know internet is always a challenge in Malawi. I'm wondering if you want to talk about some of the efforts that GAIA has made to target these key populations where there are inequities in terms of reaching out to men for testing, counseling, and referral. Can you describe some of those efforts that GAIA's made?
Yes, during our start of the clinics, so helping people in the community, we had the struggle in the uptake of HIV testing, especially to men. This was also happening in the rural areas. So some strategies were put in place to make sure that men also are not lagging behind. So the mobile HIV testing were made close to where the men gathers. For instance, marketplaces, in bars, at the taxi ranks, even the testing events were done late evening to make sure that men who went to work or do business have access to HIV testing. So in that way, more men are indeed tested, because previously we were seeing men maybe never tested. When screening them, we are finding more men in the history of never tested. But as of now, it's rare to see somebody with a history of never tested, because it has been reached at every man. Also, there were problems for men to start the ART. So there are community health workers who follow them so that they should start the ART as one way of prevention. So in that way, it has also been successful. So there also has been the moonlight where men relaxing. Yeah, HIV testing has also been there, and there's high uptake by men. So far as now, we can say indeed more things has been happening to ensure that men have been tested. As said, self-testing has also promoted more men. Testing, also index testing, it has also promoted men for testing. Maybe in short, maybe I can just say that.
Yeah, thank you so much, James. That's helpful. Just for the audience, index testing is when somebody tests positive, they identify maybe a sexual partner or a biological child that should be tested as well, similar to index contact tracing with COVID. James, I'm wondering if you can talk just a little bit more about stigma. Destigmatization is one of those issues that we really need to improve upon to drive down the epidemic. Malawi, there has historically been a lot of stigma, but can you talk about changes in stigma over the past 15 years while you've been working in Malawi and how that's impacted those coming for testing and also positivity rates?
Yes, indeed, stigma had a negative impact in terms of HIV testing, but due to health education and also acceptance by those who tested positive, even in the disclosure by the clients themselves, the stigma has really reduced. As of now, I can say there is no more stigma. So that's promote HIV testing. Yeah, here, I think in urban areas, it's also the same.
Amazing. Thank you, James. And as Michael talked about earlier, U equals U, undetectable equals untransmissible. I think that really helps to drive down stigma, knowing that HIV is comparable to a chronic condition these days. You can live a full and normal life. Michael, maybe I'll come back to you with Dr. Ellen Schell's question. She asked, does the market in progress in the development of mRNA vaccines and other vaccine strategies for COVID and other illnesses mean that we're any closer to developing a vaccine to prevent HIV infection?
Well, I think one point I would make is that the technologies that were used to try and develop an HIV vaccine over the last 40 years were really important in the development of a COVID vaccine much more quickly than one would have imagined, the messenger RNA or mRNA vaccines. But of course, an HIV vaccine is kind of the elephant in the room. It's something that in the way of prevention that's missing, and it's not for lack of effort. It's been a priority for many years now. It was promised in the early 80s, and here we are in 2022 without an HIV vaccine. But in answer to Ellen's question, I do think that the messenger RNA strategy could be very useful in developing an HIV vaccine because there are so many potential targets on the HIV virus for a vaccine, and there's a lot of change going on constantly, and that we're seeing that, of course, with COVID. And so there's a potential to have a sort of multifaceted vaccine addressing the various targets on HIV that are involved in its transmission and the development of both antibodies and cell-mediated immunity, which would be effective sort of in a combined way to develop an HIV vaccine. I know this work is going on, but I can't say much more about, I have no specific knowledge of what's going on at the companies or the NIH, yeah.
All right, great, thanks. Another question for you. We saw how flat the progress has been in the US and several other regions outside of sub-Saharan Africa. I'm wondering if you're concerned about a danger of a rebound of HIV in these areas, in the US specifically.
Well, I am, and that's if we take our eye off the ball of getting to zero, there could be a rebound. There are certain areas or specific populations that are at greater risk. I think the CDC has moved on to sort of more targeted messaging in regions that are at increased risk, the southern states, in the African American community where there's increased risk. And yeah, if we don't fund it adequately, if we don't have the adequate public health infrastructure, yeah, there could very well be a rebound. We just have to keep working. The situation today, of course, is much better than it was, but education remains an important piece, and testing and destigmatization. You know what James was saying about the reduction in stigma. I'm not sure that there's been such a parallel reduction in stigma here in certain regions of the US. And that we can maybe look to Malawi as an example, kind of leading the way.
And to follow on that, Marty asked a question. You mentioned testing is not as destigmatized here. Is it more common in the gay community to partners test before having sex? Is PrEP widely accepted as a way to prevent HIV infection?
Oh yeah, I think in the gay community, testing is much more acceptable than it was many years ago. There was worry about lists, and I think people are far less worried about who has the information. PrEP is not as widely utilized as one would expect, Marty. In the gay community here in Los Angeles, PrEP is very well accepted. It's kind of a part of our daily life. Whereas in other regions where HIV is still somewhat underground, such as the Deep South, I don't think PrEP has been as widely accepted and utilized, and I think more focused efforts to bring PrEP to the attention of people at risk in those regions would be a good strategy.
Thanks. James, I want to ask you about PrEP as well, but I think first I'll ask a question from the audience, which was, how do patients get their ART drugs in Mangochi where you work? Does GAIA deliver those drugs directly, or do they have to go to a fixed health facility? Can you speak a little bit more about how people get their ART and maybe why people in Malawi are more adherent than in the US?
Yeah, in community testing as GAIA, we don't provide the ART. We just refer them to the nearest clinic where ART is being provided. After that, then we immediately follow to the facility. If it's not available to the facility, we take also a physical address of the client, and the health workers who follow the client for linkage. Thank you.
Great, thanks so much for that. And Michael mentioned PrEP, pre-exposure prophylaxis in the US. Is this and post-exposure prophylaxis, are these things that are available in the areas where you work or in Malawi more broadly?
Yeah, in Malawi also, both PrEP and PEP is being rolled up to those who are HIV negatives and those who are at risk. There's also like health education, but mainly PEP is now here targeting more on the female sex workers or the key population. So far I can say here PEP is like targeted more to the key populations.
Thanks, James. Jamie, I'm wondering if you see any difference in the data since I think all the FIHA data was post-test and treat rollout, but do PEP and PrEP impact the data in Malawi, or do you know of other sub-Saharan African countries where those strategies are being employed and maybe we're seeing improvements?
Yes, I can say PrEP is really making some impact, because I remember some time back has also been working with the partners with the female sex workers as now, as of now, I'm also sometimes working with the female sex workers, and most of the female sex workers are being provided with PrEP. I can say they are written new positivity rate even to the sex workers has really reduced, and I understand more of the positive are just retesters, those who interrupted the treatment. But in frankly speaking, the positivity rate even to the sex workers has reduced because of PrEP.
That's great. As I noted earlier, sex workers in Malawi, I think roughly 50% of them are living with HIV. So a key population we want to target. Jamie,
Yeah,
can you speak to that progress? Yeah.
Build on what James was saying. I think it's still early days in the global community related to PrEP, in particular in sub-Saharan Africa. And I was actually just looking to my computer screen to the right to confirm the number. So PEPFAR did announce today that we now have 1.5 million people supported on PrEP in the world. That's just the subset that come through the U.S. government funding that is part of taxpayer dollars, not the privately funded NGO. So it's just one small subset. But it was only 300,000 2 years ago, and in the middle of COVID, it has been expanded to 1.5 million. That has been a huge uptick, but it's only a small subset of the need. And I also think the innovations. Well, I think the vaccine is pretty far off. long-acting PrEP is here and something that is being aggressively rolled out. And I think still, again, we're in that phase where I think focusing on these key populations and learning lessons from that, but also then thinking about how to reach, in particular, adolescent girls and young women at most at risk. It's not all adolescent girls and young women. I think really one of the challenges we have is figuring out who are those most at risk, and then making sure that they can access PrEP. But yes, I mean, I think it's still there. It's a key piece of the puzzle. It's an expensive piece of the puzzle, so it's one that has to be thought about carefully. But I do think that there's a lot in that. I think we're going to see a lot between now and 2030 of the importance of PrEP within the as one of the many tools within accommodation prevention that will get us to the end of the epidemic.
Yeah, PrEP is so key. And I think, Michael, you mentioned earlier, even there have been advances even within PrEP, making, I believe this year they announced 6 monthly injectable in PrEP. So if you can prevent HIV infections for up to 6 months with one injection, I think that will really make huge strides. And we talked about option B+ in Malawi and how the Malawi government really was committed to making that change. I know Malawi is one of very few countries that have signed on, committed to put in the resources and put in the effort to bring 6-month injectable PrEP to Malawi, being one of the first African countries to sign on to commit to do that. Michael, I don't know if you have any more to say on that.
Yeah. I think it's incredible that Malawi is at the cutting edge, with institution of immediate ARVs for pregnant women delivering, initially and now sort of test and treat, and can be at the cutting edge. I just want to see the resources brought there by not only by the government but by the manufacturers, because it's such an amazing strategy to be able to give someone 2 injections a year for prevention. Could make a huge difference.
Great, thank you. One more question for the audience, and then we'll wrap up. James, an audience member asked about targeting young men and adolescent boys. We've talked a lot about adolescent girls and young women because they are the most at-risk population. But can you talk about what GAIA does to reach their peers and test and reach young men and boys with services?
GAIA also target those population, more especially in the, as I've said, in the male-friendly services clinic, which happens on the weekend. At those weekends, the majority who patronize those services of HIV testing, targeted HIV testing, are the young men. Like in fishing areas nowadays, you found young men in the more fishing areas. Even in the markets, you find more young men. So like a men's health clinic has indeed targeted also more the young men.
Great, thank you, James. With just a few minutes left, I want to ask one final question to each of our panelists. Jamie, I will start with you. My question is, are you optimistic about the state of the HIV epidemic, given the success Sub-Saharan Africa has achieved, but given those challenges that we've highlighted across the globe, and then even in Malawi specifically with these key populations and gender inequalities? Are you optimistic, Jamie?
I am very optimistic. I have to say I'm probably more optimistic about the progress in Sub-Saharan Africa right now. I think when you can see what's happened in the context of COVID, right, both in how ministries and populations responded to the COVID pandemic, based on building on what the response was to the HIV epidemic, you can see this continued progress. I do think globally we have these challenges, in particular around more, key populations, MSM, men who have sex with men, or what's the right word? But populations that I think aren't always able to receive services, and you can see that those global numbers aren't on track. And so I do think having groups like GAIA and others that are interested in this, connecting across the globe, remembering that this is still an issue where we've made progress, but we're not at the finish line, is both important to HIV, but it's also just important to, our progress to the next pandemic or to, whatever will come after COVID. These things are all additive, and certainly, yeah, so I am optimistic, but I do have these caveats around it, I guess, is all I'll say.
James, let's go to you in Malawi. Are you optimistic that we will reach 0 new infections by 2030 in Malawi?
Yes, I'm really optimistic because even the government, the Ministry of Health, is very committed in changing some of the policies to make sure that more people are being tested, viral load is being suppressed, and the people are going on ART. So, according to the trends, I'm really sure that HIV will still end.
Great, thank you so much, James. And Michael, I'll ask you the same question, but there are 2 audience questions that I want you to answer as part of your response, which is 1, does PrEP have side effects? And 2, are the side effects with ART mild or severe these days? And will that impact the end of AIDS?
Well, sure, I think it will. There are fewer side effects associated with the newer medications. There were lots of side effects associated with the old medications. But the new medications have been refined. Yes, of course, there's side effects with everything, but they're very minimal. I mean, there's some kidney concerns that are manageable. But in terms of the side effect symptoms that patients experience taking these medications, it's unusual. And we can always find something else if the first try doesn't work. And then PrEP as well. PrEP does people need to be monitored for kidney function, but the newer types of PrEP, the 6-month PrEP is going to have fewer side effects than the current. But in terms of optimistic, I would just say, yes, I am very optimistic. They said, because they said it couldn't be done. 20, 30 years ago, they said this couldn't be done. And look at what's happening. They said that, people in sub-Saharan Africa couldn't take pills or wouldn't take pills, or that the water supply wasn't adequate for people taking pills. Right? The arguments were really kind of incredible in retrospect. So there was a lot of worry about whether this could be done, and all these international partnerships, PEPFAR, the institution of PEPFAR was a dramatic and important development. Industry has contributed, NGOs like GAIA have contributed. So I think we're getting there, and it's really, it's a heartening success story with some gaps, as Jamie has pointed out globally.
Thank you so much. I do think this is one area where the US and other parts of the globe can learn from sub-Saharan Africa, learn from their successes and build on that. So we're out of time, but I want to thank you, Michael, Jamie, and James so much for joining us today. We're grateful for the different and important work each of you do. Thank you to our audience and everyone who's joined and asked questions, and a huge thanks to GAIA's donors who make this work in Malawi possible. I hope we can reconvene next year and mark continued progress towards an AIDS-free world. Thanks all.